In this video, we will be covering fundamental concepts in chronic obstructive pulmonary disease based on GOLD 2026 guidelines. This video covers definition, pathogenesis, risk factors, etiotypes, diagnosis and assessment of COPD. Global burden of COPD. COPD is among top 3 causes of death worldwide, accounting for more than 3 million deaths each year. About 90% of these deaths occur in low and middle income countries. Despite this, COPD is a preventable and treatable disease. Definition of COPD. COPD is defined as a heterogeneous lung disease characterized by chronic respiratory symptoms such as dyspnea, cough, sputum production, and these symptoms result from abnormalities in airways or alveoli leading to persistent and usually progressive airflow obstruction. Pathophysiological components. Pathological basis of COPD includes airway inflammation and structural narrowing as seen in chronic bronchitis and destruction of alveolar walls as seen in emphysema. These changes result in airflow limitation, hyperinflation and impaired gas exchange. GET-omics concept in COPD. COPD develops due to interaction between genetic factors, environmental exposures, and time. This concept is known as GET-omics and emphasizes that COPD is a lifelong process rather than a disease of old age alone. Risk factors for COPD. Although smoking is a major risk factor, other exposures such as biomass fuel, air pollution, and occupational hazards are significant contributors. Host factors like poor lung development and childhood infection also play a major role. Etiotypes of COPD. GOLD now classifies COPD into etiotypes based on underlying causes. These includes COPD-G genetic, example alpha-1 antitrypsin deficiency. COPD-D abnormal lung development. COPD-C cigarette smoking related. COPD-P biomass or other pollution exposure. COPD-I post-infectious like TB, childhood infections. COPD-A asthma associated COPD and COPD-U unknown causes. This approach highlights that COPD is not exclusively a smoker's disease. Clinical presentation. Patients with COPD typically present with breathlessness, chronic cough, and sputum production. Many also report reduced exercise capacity and periodic exacerbations. When to suspect COPD? COPD should be suspected in any patient with chronic respiratory symptoms such as dyspnea, which is progressive over time, worsening with exercise and persistent, recurrent wheeze, chronic cough may be intermittent or non-productive, and recurrent respiratory tract infections with associated risk factors such as tobacco smoke, biomass fuel exposure, occupational dust, vapor, fumes, gases and other chemicals, and host factors. But for the diagnosis of COPD, spirometry is required in any case, even if the clinical indicators are present. Differential diagnosis of COPD. Several diseases can mimic COPD. Asthma is the most common. Heart failure, bronchitis, tuberculosis, obliterative bronchiolitis, and diffuse panbronchiolitis should also be considered depending on the clinical context. COPD versus asthma. Most important differential diagnosis is asthma. COPD usually presents later in life with persistent symptoms, whereas asthma begins earlier, shows variability, and has greater bronchodilator reversibility. Diagnostic criteria for COPD. Diagnosis of COPD requires spirometry. A post-bronchodilator FEV1 by FVC ratio less than 0.7 along with clinical features and risk factors confirms the diagnosis of COPD. Role of spirometry. Spirometry is essential for diagnosis, assessing severity, guiding therapy, and monitoring disease progression. GOLD airflow limitation grades. COPD severity based on airflow obstruction is graded from GOLD 1 to 4 according to post-bronchodilator FEV1 value. GOLD 1 more than or equal to 80%, GOLD 2 50 to 79, GOLD 3 30 to 49, and GOLD 4 less than 30%. Symptom assessment tools for COPD. MMRC grading of dyspnea. Grade 0 breathlessness only with strenuous exercise. Grade 1 breathless when hurrying or walking up a straight hill. Grade 2 walks slower than people of same age or stops for breath on level ground. Grade 3 stops for breath after walking about 100 meters or a few minutes. Grade 4 too breathless to leave the house or breathless while dressing or undressing. Another symptom assessment tool used in COPD is the CAT score. The COPD assessment test or CAT score is a standardized symptom assessment tool recommended by GOLD guidelines. It is an 8-item questionnaire completed by the patient. Each item is scored from 0 to 5, giving a total score from 0 to 40. Higher score indicates greater symptom burden and worse health status. CAT score is divided into 4 impact categories. Score from 0 to 9 indicate low impact, 10 to 19 moderate impact, 20 to 29 high impact, and 30 to 40 very high impact. A score of more than or equal to 10 indicate high symptom burden. This threshold is used in GOLD classification and often triggers treatment escalation. CAT score components. The CAT questionnaire assesses 8 components including cough, phlegm, chest tightness, breathlessness, activity limitation, confidence, sleep, and energy. GOLD ABE classification. GOLD now uses ABE classification system based on symptom burden and exacerbation risk to guide treatment decisions. The categories includes Group A with low symptoms and low exacerbation. B includes category with high symptoms and low exacerbation, and E includes category with high exacerbation risk. Comorbidities in COPD. COPD frequently coexists with other chronic diseases. These comorbidities significantly affect prognosis and must be actively identified and treated. Morbidity clusters frequently present in patients with COPD that independently impact outcomes includes mental clusters, depression and anxiety, cognitive impairment. Respiratory cluster includes lung cancer, asthma, sleep disordered breathing, interstitial lung disease, and bronchitis. Cardiovascular cluster includes systemic hypertension, heart failure, coronary artery disease, arrhythmia, and pulmonary hypertension. Metabolic disease cluster includes diabetes mellitus, fatty liver, obesity, gastroesophageal reflux disease. And multiple organ loss of tissue cluster includes osteoporosis, sarcopenia, renal failure, and anemia. To summarize, COPD is a preventable and treatable disease resulting from interaction between genetic and environmental factors across a lifespan. Diagnosis requires spirometry and treatment is gated by symptom burden and exacerbation risk.